بسم الله الرحمن الرحيم. شرف إن أنا أتواجد مع حضراتكم النهاردة. دكتور محمد أبو الهنين، أستاذ جراحة المسالك البولية جامعة طنطا. النهاردة هنتكلم عن we will talk about an important attractive issue which is male infertility and how to deal with these patients. Our ideal today is to define infertility and the difference between it and sterility, review the concepts of fertility, also to know the causes of male infertility, and how to deal with a patient with male infertility. At first, we must define what is meant by male primary infertility. It is inability to conceive after 1 year of regular unprotected sexual intercourse. And what is the difference between primary and secondary infertility? Both of them cannot conceive after regular unprotected coitus for 1 year, but in primary infertility he has no children. In secondary infertility he has children, but followed by a period of infertility. The difference between infertility and sterility is that infertility can be treated due to presence of causes, while sterility cannot be conceived all over his life. It may be due to absent testes or something like this. The incidence of these cases of infertility all over the world is about 15%. The main causes constitute male causes is about 40%, while female is responsible for about 40% of causes. Both male and female sharing both of them of each other in about 40% of. This diagram shows the actual percentage between male and female constitute. We show that also there is about 6 to 8 million couples in USA has. We must talk with us. What is the function, testicular function? The function of the testis constitute two components. Is either endocrine function or exocrine function. Exocrine means production of sperms. Endocrine means production of testosterone, which is an important in fertility for male patients. The main cause of testosterone, as we know, about 98% from the testes in its biosense, while 2% from adrenal gland. About 2% of the serum testosterone is present in the serum in free form, while 98% is bounded to globulin. Also, testes secrete another hormones like testosterone, which is called activin and inhibin. We also must remember that certain hormones in the body, like estrogen, thyroid hormones, also decrease the serum testosterone. As the exocrine function of the testis, in which there is spermogenesis and spermatogenesis. We must know the cells which are present within the testis. It is present in the form of Sertoli cells, which is responsible for the blood testicular barrier. Also Leydig cells, which is an important cell in production of hormones. Also germ cell, and this is the target of our lecture today, in which it is formed of spermatozoa, which is the first cell of reproduction, followed by maturation into primary spermatocyte, then secondary spermatocyte, then spermatid, and by mitosis. This occurs due to meiosis and mitosis. This diagram shows the different types of cells, germ cell, within the testis. which is start with spermatogonia and end with which is from which has 46 chromosome end by sperms mature sperm which contain 43 chromosome 23 sorry 23. This slide shows the histological pattern within the testes. As we know that spermatogenesis take certain cycle within the seminiferous tubule. It lasts or constitute about 60 days after due to formation of mature sperm. Then maturation will be occur within the epidermis. It lasts about 10 to 15. As regards to the female, as we know that fertilization will occur within the middle of the female menstrual cycle with some physiological changes which occur within the uterus and the cervical mucus. Also, fertilization occurs after a chromosomal reaction at the zona. This diagram is a beautiful, important diagram which shows the interaction between the mature sperms and the wall of the egg or ovum. It starts by adherence of the head of the sperms, as we show to the vitelline layer that surround and the mucus that surrounds the ovum. It will try to be stuck to the protein receptors to the cellular wall of the ovum. Then it will be union and fused with the plasma protein membrane of the ovum to evacuate the nucleus and the genetic coding of material of the sperm, which is present in the head of the sperm. This is a microscopical under microscope shows that the wall of the ovum is present and hundreds of sperms surround the ovum trying to penetrate its wall. Now we will discuss the different causes of male infertility. As we know, the main factory or the main biosynthesis of spermatogenic cells or sperms is present within the testis. But there is a stage before the testis can be deteriorated or can be maybe the cause of infertility within this area. Also after formation of sperms, mature sperms, and its delivery to the female partner, there is a long tract, and there is some causes also present after the testis, which is called pre-testicular causes and testicular causes and post-testicular causes. Before going to the different causes through this classification, there is another classification according to the prevalence of the different causes. We find that the idiopathic type of infertility, male infertility, is very high. It is present in about 1/3 of cases. The second cause is varicocele, about 16.6% of cases. Also infection as a rule, about 9%. Hypogonadism, cryptorchidism, malformation within the genitourinary tract, systemic causes, immunological causes, tumors, and obstruction. It's very important. This is the main very important causes according to the prevalence and percentage. As regards to the idiopathic male infertility or subfertility, we must know it constitutes, as before, about 1/3 of causes. It is increased in some cases, in some areas, as it is high, about 75% of cases in some areas, especially in Africa. and considered the main cause. Its etiology is unknown, but some theories is put forward to be understood, like free radical induced damage to the sperms, as this free radicals is defined as it is oxygen molecules containing one or more unpaired electron in the atomic or molecular orbitals. As regards to the main classification, which is the pre-testicular causes of infertility, this means it is the stage before the going to the testes. It depends on different hormones that prepare in biosynthesis of sperms, like in hypothalamic diseases, as gonadotropin deficiency, which is called the Coleman syndrome, isolated LH deficiency, isolated FSH deficiency, congenital hypogonadotropic syndromes. Also, there is a pituitary causes. It is a pituitary insufficiency hormone which occurs due to tumors or secondary radiation or different operation within the pituitary gland. The second main causes is hyperprolactinemia. Also, certain exogenous hormones like estrogens and corticosteroid can disturb the sperm biosynthesis. Growth hormone deficiency also. As regards to the testicular causes of fertility, it is usually during manufacturing or biosynthesis of sperms. There is different abnormalities can occur, like chromosomal deficiencies, like Noonan syndrome, myotonic dystrophy, vanishing testes syndrome, which it occurs as a bilateral anorchia, Sertoli syndrome, different chromosomal microdeletion, chromosome Y microdeletion, gonadotoxins like drugs, radiation, different systemic long-standing diseases like renal failure, liver failure, sickle cell anemia, androgen activity, defective androgen activity, testicular injury due to drugs, trauma, orchitis, torsion, cryptorchidism, varicoceles, and some. As regards to the medication and the drugs and its association with infertility, there are some drugs already known to be induce infertility, like ketoconazole, spironolactone, alcohol, cimetidine, marijuana, heroin, methamphetamine. All these drug medication or drugs act by inhibition of testosterone synthesis. Pesticides also has an estrogen-like activity. Chemotherapy, calcium channel blockers as colchicine, albuterol, antidepressant, antipsychotic, and nitrofuran. As regards to the post-testicular causes of infertility, it is divided into three main groups. The first group is reproductive tract obstruction or obstruction, congenital atresia, a blockage of the tract after the tests, congenital absence of vas, Young syndrome, idiopathic epididymal obstruction. Polycystic kidney disease is associated with absent vas or atretic epididymis, circulatory duct obstruction, vasectomy, infection, groin surgery, cutting off the vas, functional blockage, sympathetic nerve injury. Also, there is some disorders affecting the sperm function and the motility, as the sperm is already formed, but it is malfunctioning, as in Montgomery syndrome, as maturation defects within the epididymis, immunological infertility due to presence of antibodies that cause deficient movement or deficient function, infection and its toxins, Also, there is disorders of coitus is regarded as a post-testicular cause infertility, as erectile dysfunction, hypospadias, and the timing and frequency of coitus deficiency with the timing of ovulation. Besides the male infertility, you must evaluate the female also, or female partner, by history taking, physical examination, laboratory tests, radiological evaluation, and diagnosis. Diagnosis of male infertility depend on the history taking. We must know the duration of infertility after marriage, presence of early pregnancy or not, sexual history with timing, frequency, use of lubricant is very important during sexual act, medical and surgical history as fever, active infection, surgical procedure of the gallbladder, disease, childhood disease like mumps, orchitis, and cryptorchidism, medication as we told before, also family. Physical examination of the male patient is very important. Virilization symptoms like body hair and gynecomastia. Examination of the scrotum and external genitalia is very important, especially the tests for the size and consistency. Presence of vas, presence of leukocyte, and epididymis abnormalities. Our patient must do some laboratory investigation like urine analysis, semen analysis, but the semen has certain precautions. We must tell the patient it must be 3 to 5 days of sexual abstinence. We must examine seminal fructose and post-ejaculate urine analysis if needed in some cases. Fructose, why fructose? As we know from the seminal vesicle. Absence of fructose means there is obstruction, ejaculate obstruction or seminal vesicle obstruction. Also, some hormones must be assisted in this patient, like FSH, testosterone, and prolactin. This slide shows the different sperms under microscope. This criteria, WHO criteria for normal semen value. As we do semen examination, we searching for the volume must be not less than 2 milli, pH 7.2, the sperm concentration 20 million per milli, but this is an old figure. The recent figure is about 15 million per milli, and this is after this figure is from about 5 years. A total sperm count within the semen sample is about 40 million or more. The motility must be 15% or more. The morphology 30% normal figure or more. The vitality about 75% or more must be definite sperms. White blood cells less than 1 to 5 cell per high power field. Parameters we must looking for during semen examination. As regard, we told you before that we must do fructose test in some cases, as it is very important. It's a normal level about 120 milligram per deciliter. It is significant. Its presence exclude seminal vesicle obstruction or malformation or absence in the vesicle in some cases. Indication of hormonal evaluation is very important also, like FSH, testosterone. It is indicated in cases of sperm density less than 10 million per milli. Also in some cases of impaired sexual function like loss of libido or impotence. Also we indicate to do hormonal evaluation if there is associated. Imaging tests in these cases we must do ultrasound, scrotal or transrectal ultrasound, and to this extent we use CT or MRI. Vasography, it is not needed today. Ultrasound is an important tool of diagnosis in cases of infertility. Abdominal ultrasonography, it is used mainly or in cases of vasogenesis. It is usually sometimes associated with renal malformations, but scrotal duplex ultrasound is needed on our cases of infertility. It is important to detect some scrotal abnormalities that may be not palpable. It may also be used to detect blood flow and any changes within the venous system or arterial system of the testes. It is also used for diagnosis of subclinical and clinical varicocele and to detect its grade. It is used also to detect the testicular area of rich blood supply if we use sometimes in some cases of for testicular biopsy to gain sperms with it. As regards to the duplex is very important as we know in these cases of infertility. It is used to as a criteria of diagnosis of varicocele in the testis if the veins, the dominant veins is more than 2 mm in supine and increased on standing or valsalva maneuver more than 1 mm. It is diagnosed in standing or valsalva if it become about 3 mm or more. It is considered as a screening test also in all cases with abnormal. Transrectal ultrasound has a diagnostic indication in patients with low ejaculatory volume, also in patients with no ejaculatory volume, but in specified cases like hemospermia, painful ejaculation, persistent or unexplained oligospermia or athenospermia with normal clinical examination and normal hormonal profile, also in cases of persistent biospermia and cases of chronic prostatitis. Also in abnormal palpable something within the digital rectal examination. It is used as a screening test. Also, it is important in cases of negative seminal fructose test. Sometimes thus-guided seminal vesicle aspiration can be used. Also, transrectal ultrasound is important as a and has therapeutic indication in cases of fine needle aspiration of Mullerian duct cyst. Also, it can be used guided guided transurethral resection of in cases of ejaculatory duct obstruction, and also in cases of laser therapy of incision in cases of Mullerian. To know what is abnormal finding during transrectal ultrasound, we must know the normal. In transrectal ultrasound, measurement of the prostate is about 20-25 millimeter. Seminal vesicle has a length and with its length about 30 millimeter and about 3 centimeter. Its width about 1 centimeter. Ampoule of the vas difference is its diameter about 5 millimeter. Ejaculatory duct diameter less than 2 millimeter. Any variation about these measures is considered as abnormal signs and is suggestive for obstruction. If the seminal vesicle is width more than 1.5 centimeters means maybe obstruction. Dilated ejaculatory tract more than 2.3 milliliter is indication for obstruction. Also, the presence of calcification or cyst or some stones within the ejaculatory duct may cause obstruction and can be diagnosed by transrectal. This figure shows how to do mapping or fine needle aspiration of the testes. Testicular biopsy is very important. It can sometimes it is used for the diagnosis or gaining sperms if in cases of azoospermia. The gain or already present of sperms is diagnosed and graduated according to the Johnson score from 1 to 10 grades. 10 means complete spermatogenesis with many normal spermatozoa, while 1 means no cells in the tubular secretion. This means that there is a complete hybridization of the seminiferous tubules. What is therapeutic testicular biopsy? Testicular biopsy can be gained through different techniques. First, TC. TC, it is an abbreviation of open testis sperm extraction. Micro-TC, it is abbreviation for microscopical testicular sperm extraction. TISA means percutaneous testicular sperm aspiration. Seminal vesicle aspiration, sperm aspiration can be done also. Normally, it is considered positive if there is more than 3 sperm by high power field. And if we want to do it, we must ask the patient don't be in sexual practice for about 20 days. Also, for one of the diagnostic surgery is the seminal vesicle colon-tubation. Also, vasography. It can be done by different techniques as transscrotal, transrectal, transperitoneal, transurethral. All this, finally, this is the algorithm of cases of azoospermia and how we and find that most of them we discussed.